Can
Yes,
everyone
yes,
see
we
my
can.
screen? Okay, so for some reason, sorry, these are technical issues. The presentation's now coming up on my other screen, so excuse my side view.
Okay, no, it looks perfectly fine from my side, from my end, and we are back live.
Okay, but now I can't move it. Sorry.
Oh, okay.
Sorry, can you just give me a minute? Can you see my slides again?
Yes, we can, Sue-Ann.
Right.
Yes.
But now I can't. Okay, let me do this. Okay, sorry, technology is not my friend today. All right, so this is the a similar table, again showing, but stratified by the different sub-districts in each province. And I know it's busy, but the format is the same. And what I've done is highlighted the sub-districts where we only implemented the hospital intervention in green, and sub-districts where we've implemented both interventions, the hospital and the at PHC level, in orange. And what I wanted to share with you here is that in the sub-districts where we implemented both interventions, we saw a higher relative reduction in initial loss to follow-up in KZN. So you can see the reduction was greater in Rayon Kunyeni compared to Umdoni. And then in the Western Cape, there was a greater reduction in Khayelitsha compared to Tygerberg. And there was still no significant change in Gauteng, even when we look at the results stratified by sub-district. So this table now only has the sub-districts where we implemented both interventions, and we've stratified it by hospital and surrounding primary healthcare facilities. And here we found a relative reduction, a higher relative reduction in the primary healthcare facilities around the hospital, but not in the hospital itself, in both Rayon Kunyeni and in Khayelitsha. And then this table has the 3 sub-districts where we only implemented the hospital level intervention. And again, we've stratified it by the hospital and the surrounding primary healthcare facilities. And here we see a couple of interesting things which you weren't necessarily expecting. So at GJ Crooks Hospital, we did see a relative reduction in initial loss to follow-up of 40%, but we never saw this in either of the other hospitals. If we just think about GJ Crooks Hospital and Tygerberg Hospital, for example, GJ Crooks was a district level hospital with a TB focal point. So patients leaving the hospital could go via the focal point and receive some support for linkage. Whereas Tygerberg Hospital, a much larger hospital, it's a tertiary level, and there's no TB focal point. So this could have played some role in this result. And then if we look at the facilities around Tygerberg Hospital, we do see a reduction in initial loss to follow-up of just under 25%. And this really wasn't expected, and it's quite interesting, and we're not sure why. One of the things we thought about was within the Western Cape. As I mentioned, we were using the Provincial Health Data Centre, and even though we were only working at PHC level in Khayelitsha, there was a drive for health staff to use the TB line lists in other sub-districts to try and support linkage. So this could have played a role in this result, but we're not really sure. The other thing to think about when we're comparing the hospitals and the primary healthcare facilities, we know mortality is much higher in the hospitals, but we haven't actually teased this out here in this slide. And then I just wanted to draw out one more finding and using the facilities on this slide. So if you look at the numbers diagnosed at hospitals, there's fewer people diagnosed compared to those diagnosed in the surrounding facilities, and that's very much expected. But you'll see the proportion initial loss to follow-up is much higher in hospitals compared to facilities, and that's consistent across the provinces. So, but you can see that at Barra, 63% compared to 18% in the intervention phase, and 45% at Tygerberg compared to 14% at the surrounding facilities. So just to go through what does all of this mean? So there were very different findings across the settings. And I think this kind of points to different contextual factors. So when we're thinking about initial loss to follow-up and we're thinking about interventions to reduce initial loss to follow-up, I think it is important to think about the context in which we're working. I think the findings also point to the complexity that exists within trying to reduce initial loss to follow-up. And again, I think this highlights that we need to kind of have a good understanding of the setting in which we're working and how the different factors play a role in initial loss to follow-up. We found that initial loss to follow-up was higher at hospitals than at primary health care facilities. And so we also need to start thinking about what can we do at different levels of healthcare and additional interventions that we could put in place at hospitals to try and bridge that gap between going from a hospital to linking to care to primary health care facility. And then I showed you that the reduction in initial loss to follow-up was greatest in sub-districts where we actually implemented both interventions. So there seems to be some benefit in registering persons with TB in hospital and in following up all persons consistently, irrespective of where they were diagnosed. And then a couple of critical success factors, which I think we can take out as key lessons learned and things we need to take forward in thinking about interventions to reduce initial loss to follow-up. I think the first thing is consistent follow-up is essential. Whether you have a manual process or an automated process, just following the process consistently and following people up is important. And then I wanted to just pull out healthcare worker communication and to start thinking about how can we improve communication between healthcare workers and newly diagnosed TB patients, especially those diagnosed in hospital. They may require additional support, they may require a bit more time spent with them to promote linkage. And then anecdotally from KwaZulu-Natal predominantly, we got feedback that patients really preferred it when we made a telephone call, and it could be this two-way interaction where they could also communicate difficulties around linkage. And I think that's also important to think about when we are are planning interventions. And then, of course, contact details has come up many times before. We really need to find a way to check patient contact details at every healthcare visit. During LinkedIn, we printed labels and we put that at all prominent places within health facilities. That didn't really have any effect. And we were further thinking that potentially we could offer patients incentives to voluntarily update their contact details. And then the last point I wanted to raise here is just as the intervention continued during LinkedIn, and as time went on, the whole process became much more streamlined. Personnel were trained, and the time to actually carry out the intervention reduced. And I think this was important because potentially what we were doing, the type of intervention, could easily become part of the routine health services without additional personnel and not an extra amount of too much time required. So I know I've gone a little bit over time now because of the technical difficulties, but I just wanted to touch base on 2 additional activities that were implemented in the Western Cape only. The first one was at Khayelitsha District Hospital. The preliminary analysis showed us that there was this much higher initial loss to follow-up in hospitals, and we wanted to see if we could interact with patients and how feasible this would be. And so we implemented this patient interaction process in the last 5 months of the intervention period, where we identified who was in KDH still. We went to find them in the hospital. We spoke to them. We asked them about their any updated contact details. We provided them with the opportunity to ask questions or raise any issues they had with linkage. We spent a little bit of time with them on looking at where they would link to care after they were discharged from hospital. So just a few of the findings from that. We interacted with 84 patients, and the majority of them did link to care after they were discharged. The whole interaction process took about 20 minutes, which we felt was feasible and could be taken over and perhaps become part of the discharge process routinely. Of those 84 patients that we saw, 64% of them gave us an updated telephone number, 23% gave us a change in physical address. So it really just brings to the fore again the need to update patient contact details. And then anecdotally, they really welcomed the health information and they had lots of questions for our team. So we really do need to think about patient-centered interactions when we're developing interventions going forward. And then the second activity we called the systematic follow-up process, and this was implemented in Khayelitsha sub-district between January and December 2020. And we did this because we realized that after the referral to the community healthcare worker for a home visit, there were very few patients that linked after that process. So we wanted to see if we could potentially find and support linkage for those patients if we threw all our research resources at it. So we had a team of 2 full-time research assistants, and they had all the necessary resources, that a dedicated vehicle, a GPS, all the necessary data and airtime that they needed. And they received lists from the data center of people who had been diagnosed with TB, had gone through the cascade of LinkedIn interventions, and they still hadn't linked to care. So they systematically firstly visited the primary healthcare facilities just to double check that the patient was, to check if the patient was registered at facility level, and perhaps the information hadn't flowed up to the data center yet. And then they contacted the patients telephonically if they were able to check their home address, and then followed that up with a home visit. And obviously for those that they didn't have contact details or they were incorrect, they just automatically did a home visit. And I just wanted to share with you what we found. So of the 406 patients they needed to trace, more than a third had actually linked to a facility, but that data just hadn't been fed up to the data center for different reasons. So it just highlights the importance of accurate data captured in real time can really reduce the resources invested in tracing people who actually are already in care. And then I know this diagram's a little bit small, but I just wanted to highlight a couple of things. So we had to go out and do a home visit for 219 people, and we could only find half of those. So we found 51% of those patients. And the other next interesting point is that half of those patients that we did find had actually linked to care in the time between checking at the primary healthcare facilities and us finding them in the community. And then if we look at linkage to care for both groups, those that we traced and found and those that we tried to trace and could not find, a similar proportion actually linked to care at the end of the day. And so I think this just raises a couple of points around when should we do home visits? How much time should we give patients? Not everyone links to care immediately, although that is what we would like to work towards, but some people may just need a little bit more time. And then this is the last slide. I just wanted to try to kind of bring this all together and to think about this in your setting, and potentially the three components that would need to be considered when we're thinking about linkage to care and implementing interventions. And we need to think about the person behind the TB diagnosis and think about who are they, how do we improve communication with them, how do we tell them to link, and why do they need to link. We need to think about patient-centered approaches and address their concerns, and work towards closing the knowledge gap and enabling them to better understand their TB diagnosis. From the qualitative work, which I haven't showed here, a lot of people had had TB before, but their symptoms were very different. And now they were asking, last time I had TB, my symptoms were X. Now I no longer have X. Now you're still telling me I have TB. So that kind of thing. And then as health services, I think we need to focus on persons diagnosed in hospital. We need to try to find a way to better engage patients prior to their discharge and find a way of updating contact details at each visit. And then in terms of technology, real-time data is obviously optimal, accurate data is important, but I think we really can leverage the systems we have available to us. So in the Western Cape, we're very privileged to have the data center, and it's a wonderful resource. But in other provinces and where we worked in KZN and Gauteng, they are the waiting for TB treatment lists in tier.net. And if we can start using those well and consistently, I do think that would be beneficial. So I'm going to stop there and apologize that I have gone slightly over my time, Mike, and over to you.
Thanks, Sue-Ann. And no, that was great. It's a really good platform for me to talk about the economics of all of this. And so I'll try to be brief and leave a good amount of time for a discussion and questions at the end. Sue-Ann, do you want to move on to the next slide? So just basically our objective was to try to figure out how much does LinkedIn cost? How much did it cost us to actually implement this intervention? And including how much does it cost to operationalize the Provincial Health Data Centre in the Western Cape, which provided support to the LinkedIn intervention there at the facilities in the Western Cape. And then to try to get a sense of, well, is it worth it, given the costs that are incurred in implementing the intervention? Is it worth it? Is it cost effective? and where are the potential efficiencies that might be generated by the utilization of the Provincial Health Data Centre in the Western Cape. So we did an activity-based costing, which basically is an economic technique where we try to identify each of the activities that were needed to implement each step of the intervention, and so breaking that down between what the LinkedIn intervention actually did at the hospital level, what it actually did at the community level in following up patients. And we took a micro costing approach. So rather than trying to understand the costs from budgets or from expense reports, trying to get a sense of within each one of those activities, what are the actual resources that are required to conduct that activity, and then what's the value of each of those resources. We took a provider perspective because obviously we're trying to understand what is the cost to the health system, what might be the cost to the health system in implementing an intervention like this, and to try to understand what the value is there to the system. And we focused then on three primary components: the operations of the Provincial Health Data Centre in the Western Cape, and we excluded things like development and of new modules and the development of the actual databases and systems and the research that's gone into that, just to try to understand the costs of running the data center in the Western Cape. The second component was then obviously the implementation of the LinkedIn intervention in the Western Cape and in KwaZulu-Natal, and we didn't do the costing study in Gauteng. And then finally, to understand what's the added value, what's the added cost, and then what's the added value of implementing that really fine-grained systematic follow-up process in the Western Cape. Thanks, Suan. And so you can see here, this is just the sort of the diagrammatic interpretation or description of how we broke the interventions up into the different activities, between the setting up activities, between the hospital intervention and the community interventions that happened at the PHC level, and including the training that happened at all levels and throughout the process of the intervention, of implementing the intervention. And then at the bottom, the orange box showing the activities that we included as part of the systematic follow-up process, which was that add-on intervention that happened in the Western Cape only. And the figure on the right-hand side just showing, you know, a sort of a stepwise description of how people come into the system and how the intervention then is rolled out to try to link patients who would otherwise be lost to follow-up, to link those patients to care. In terms of so I'll dive straight into the costs then. So in terms of the costs, you can see that row at the bottom that says total costs. The total cost in KwaZulu-Natal is about $3,300, and that's for the full 2 years that the intervention was implemented. The cost of running the PHDC for those 2 years and the bits that we apportioned to the TV support that they were giving to the LinkedIn intervention to run in the Western Cape was about $618. And the intervention cost in the Western Cape about $3,600. So the total cost of the LinkedIn intervention, just the standard LinkedIn intervention in KZN and in the Western Cape, about $7,500 for the 2-year operationalization of the intervention. Interesting to see that the systematic follow-up process, which was just a year's worth of activities in the Western Cape, was about $6,500. And of course, it's not entirely unexpected. We know that it was a very resource-intensive process to follow that up. Suan, if you'll click, so just to highlight here that the primary driver of the costs across the board for LinkedIn were the staffing costs, the personnel costs. And of course, the LinkedIn intervention really is reliant on people based in the facilities at the hospitals, at the primary healthcare facilities, and the community health workers that are doing the follow-ups. And so that's not entirely unexpected. And then just to note also that the cost of the PHDC accounted for only about 8% of the total cost of the LinkedIn intervention across the board. So really not a huge additional cost of operationalizing the PHDC and the support that they were giving to the LinkedIn intervention in the Western Cape. This is just another slide that shows the costs of the intervention, but broken down into each of those individual activities. You can see the box of activities on the right, in case you want to know exactly what those activities were. But basically, you can see how the costs are apportioned. Actually, quite small intervention costs in the hospitals, but a lot of the costs incurred in the intervention in those community-based interventions in the following up at the PHCs. You can see there also high costs associated with the activities in the systematic follow-up process, and then relatively small costs comparatively of operationalizing the PHDC in the Western Cape. Thanks, Anne. So this is a table of basically the results of the costing of the PHDC. Again, a fairly high proportion of the costs there allocated to staff. Obviously, there's very technical positions here, data people that are doing fancy things to link systems and to curate the data and check quality and make sure that the systems run. But really, there for a total monthly operating cost of about $75,000 to operate the PHDC. And what we did is, with support from colleagues at the data center, we figured out a way to apportion these costs, firstly just to the TB activities that they're engaged in, which we estimated was about 22% of the total effort of the PHDC, and then allocated that across all of the facilities that they support in the Western Cape, and then whittled that down to just the 15 facilities that they were supporting for the LinkedIn intervention, and then including, of course, overhead costs, so that ultimately, again, we see here that there's a high staffing cost, a high personnel cost, but really ultimately with just about $620 apportioned to the LinkedIn intervention. Thanks, Joanne. So in terms of the cost effectiveness analysis, really a simple calculation to calculate the incremental cost effectiveness ratios, dividing the extra cost of implementing the intervention by the extra effectiveness, the additional number of people that are linked to care, and then disaggregating by province, by sub-district, and then, of course, separating out the systematic follow-up process. And so here you can see a table which Sue-Ann presented earlier, just calculating the expected loss to follow-up without the LinkedIn intervention, comparing the intervention figures with the baseline, and to try to get a sense of how many additional people were linked to care because of the intervention. You can go ahead, Sue-Ann. And so again, these number of additional people that are linked to care in KZN and in the Western Cape, about 210 additional people linked to care in KZN, and about 417 additional people linked to care because of the LinkedIn intervention during the intervention period in the Western Cape province. This table is a little complicated, but really the focus here is on the incremental cost effectiveness ratio. And the idea is that the lower that dollar figure is, the lower the cost per additional person that's linked to care. And so we could see the intervention at the Tygerberg Hospital and the hospital in Mdoni. At the Tygerberg Hospital was the most cost effective, but really that's a result of there being really relatively low costs in total at the Tygerberg facility. Overall, the incremental cost effectiveness lower, which is better in the Western Cape province than in KZN. But partly what's driving cost effectiveness in KwaZulu-Natal is that actually the percentage of additional patients linked to care was quite high, But because those numbers, the absolute numbers were lower than the actual number of people linked in the Western Cape, that intervention in KwaZulu-Natal was not quite as cost effective. Thanks, Suanne. I guess not surprisingly, then, in doing the cost effectiveness analysis of the systematic follow-up process, that incremental cost effectiveness ratio, $2,100 per additional person linked to care, compared to an average of $350 for the LinkedIn intervention. And a big driver of that is, of course, is because there were so many people that were being followed up that needn't have been followed up because they'd already been linked to care. So there was a lot of intense effort to try to find people and link them to care who had already linked on their own. Again, this figure of $2,000 per additional person linked to care is relatively low if it means that we're averting deaths. And so we weren't able to link our data about the number of people that were additionally linked to care with the number of deaths that were actually averted and the amount of morbidity and mortality that we actually averted. And so that's additional analysis that needs to be done. Thanks, Suanne. And then finally, just some discussion points. The cost of reducing initial loss to follow-up between about $100 and $500 per additional person linked to care, which is quite low for an intervention like this. We saw that cost effectiveness increases as the number of additional people that are linked to care increases, of course, because we're spreading the costs of the intervention across more people that are linked to care. We found that the cost of running the PHDC is relatively low, and that cost decreases as more disease areas are covered and as more facilities are served. But really, one of the key findings here is that having good real-time data is really, really key, and not just accurate data and high-quality data, but also data that are linked across the different systems that we're using in the healthcare system. And that automation and tracking and tracing interventions could potentially help to reduce the burden on facilities, improving efficiencies and improving coordination between the hospitals and the PHDs. And then the big question, obviously, is how do we link this to outcomes in terms of morbidity and mortality, disease and disability linked with reducing initial loss to follow-up. So I'll stop there. Sorry to rush through the results, but I think really positive. I think economic results in terms of the cost and value for money of this intervention. Thank you.
Thank you so much to our speakers, and thanks for their time. We are now going to head over to our Q&A session. Please keep the questions coming in, and should we run out of time, we have asked that our speakers respond to you at a later stage. So we have a comment here that says that another way to think about the results is that the hospital intervention did not work, irrespective of whether it was done on its own or together with PHC intervention. Hospitals clearly need a different approach. And secondly, we have another comment with a question. Thanks for the great presentation. In the estimated percentage of loss to follow-up, do you also adjust or account for the percentage dying and those who eventually do link to care at a later stage, or perhaps linked at other health facilities? So our speakers can respond to that last question.
Sure. So the first comment about, do we need a different approach at hospitals? Did the intervention work? I think that we need to understand who's being diagnosed at hospitals. And I think it would also be beneficial if we could understand, if we had a good grapple on patients admitted in hospital and those diagnosed as outpatients, because those are also two different types of patients. and follow-up would be different from them. Those admitted in hospital, they're in hospital, you can hopefully find them and you have an opportunity to engage with them before discharge. Those that are diagnosed as outpatients, you need some kind of communication or enhanced engagement with them before they leave so that they come back and get their TB result and link to care. In terms of patients dying, so we know mortality is much higher at hospital level. These are typically sicker patients who are accessing care much later. Potentially, these patients don't typically access primary health care, and so that's why they've ended up at the hospital at a late stage. We did look at mortality amongst initial loss to follow-up patients in the Western Cape, and that's been published. But we didn't account for mortality in these in our analysis here. So potentially more patients did die from that were diagnosed in hospital, and that would have affected the there were obviously less to link to care, and that resulted in lower or less of an impact of our intervention. I don't know if Mohammed's on the line and wants to add anything to that.
He would not be able to add unless it's a comment via our Q&A, Dr. Suen.
Okay, if we want more details, then we can actually, write to specific people.
Yes.
I think one of the things that we were grappling with when we were trying to understand, the cost effectiveness, because obviously some of the people who may have been initially lost to follow-up but then linked to care could have died. It's very difficult to get a comparator to understand what are we comparing that against. How many of the people that remained lost to follow-up after the intervention died, but they're lost from our data. So we didn't manage to find them ever. And so to know how effective reaching these patients and linking them to care at all compared to not linking them to care, what that means in terms of mortality is quite difficult. It's quite a difficult number to estimate. And we could do some sophisticated modeling, but without better data in terms of the comparator, it's quite difficult to know then what we're comparing our linkage to care intervention with.
Thank you so much, Mike, for that. I think we'll have our last two questions. We have a question asking why was the Gauteng province excluded from the costing? And then secondly, it's a question that if the intervention results are that most of the patients were incorrectly captured as initial loss to follow-up, thus we need a web-based tier.net to eliminate reporting poor linkages.
I'll have a crack at why we didn't include Gauteng in the costing. Part of it was a availability of resources issue. Obviously, it's expensive to do research, but part of it also was that in Gauteng province and in KZN, the intervention ran quite similarly based on existing databases and existing systems, whereas the costing in the Western Cape included additional dimensions, the additional dimension of the provincial health data center and the systematic follow-up process. So it gave us sort of a comparison between a standard practice in the absence of a data center and then a comparison to a province that runs with a more sophisticated back-end data center that coordinates between the different databases.
Thanks, Mike. Nolwazi, won't you just repeat the second question? I can't really add anything more. It was a methodological decision to not include Gauteng. And I think when we made that decision at the beginning of the project, we also thought KZN and Gauteng were similar in terms of the data sources being used. So we thought we would use the NICD lists and tier.net in the one setting and the Provincial Health Data Centre in the other, and kind of compare. But if you can just repeat the second question.
Thanks, will do. It was starting with, if the intervention's results are that most of the patients were incorrectly captured as initial loss to follow up. Thus, we need a web-based tier.net to eliminate reporting poor linkages.
So I don't think it's correct to say that most were initial loss to follow up. There could have just been delays in linkage. So remember, our definition was anyone who wasn't linked within 30 days of diagnosis was termed initial loss to follow up, but people could have linked after 30 days. And they would still be counted within our definition of initial loss to follow up. So hopefully that answers the question. But obviously, live tier would be better, but it would be obviously dependent on capturing in systems, because if we can get real-time data, that is obviously better than working retrospectively. But yeah, hopefully that answers the question.
Thank you so much, Sue-Ann. I'm not sure if we have time for another question. Perhaps my colleagues can advise me. But in the meantime, I'd just like to announce that within the month of September, we'll be having 2 webinar sessions instead of 1. And the first one is a special session which will be taking place on the 11th of September in advance of the UN high-level meeting on TB, which is to showcase the advocacy pieces brought forth to the meeting. And we hope you will be able to join us for this, as well as our regularly scheduled sessions, such as the one that is being shown right now on your screen. So this one will be taking place on the 18th of September. And it is titled Umoya Omuhle, TB IPC in Primary Healthcare Centers, What Works and How Can It Be Implemented? So those are our 2 upcoming webinar sessions, which we hope you can join us in. Thanks, Mtoga. Next slide. And just be reminded that if you'd like to be on this platform, a monthly platform, and you'd like to present your work, please email myself at the email address that is shown on your screen, ngosi@tbthinktank.org. And thank you for your time, colleagues. Please enjoy the rest of your day further. Thank you so much.
Perhaps, Sue-Ann, if you have a moment or two, you can just respond under the published Q&As. There are a few remaining questions there that people had, but thanks everyone for joining us.
Thanks, will do. Bye-bye.